So I'm slightly involved in one that's looking at gay and transgender male to female and bisexual men in the Americas. So it involves a couple sites in the States as well as in Peru and Brazil. And that is looking at what are the intervention components that make sense for those populations that we might package together and then see the synergistic effect of. So it could be, they're still figuring out what it might be through these modeling exercises that get very complex about transmission dynamics and access and uptake and all that kind of stuff. But it could be some combination of, believe it or not, male circumcision. In some of the Latin American contexts, it's more desirable than in the US, where it will never fly with adult males for the most part, gay men. PrEP, which now we have some data about, some kind of sexual health intervention, and hope if there is a rectal microbicide, for example. So we're not sure which components will be in the package, but that's the idea, is to identify what makes the most sense in this package, and then that could test the efficacy and the effectiveness eventually. So that's the NIH's version of combination prevention. And then John Merman, also at the Retrovirus Conference, talked about a new version that the CDC is using for its own way of thinking about what are the kinds of prevention projects we should be doing as a combination, and suggested that they have to be high impact. That what we really want to focus on is not just a combination, but a high impact set of prevention strategies, and the key components of which are their effectiveness and their cost effectiveness, feasibility for full-scale implementation, do they cover and target the right populations, and the interaction of them. And the rationale he gave is, it's not just about combining interventions, because combining them is not necessarily enough. All interventions are not equal. They're not equally effective. And we have limited resources. I'll say more about that. So we all have to prioritize. So high impact prevention. So the point here is that whatever we want to call it, combination prevention by any name, combination prevention, highly active prevention, prevention packages, high impact prevention, they're all versions that emphasize this multi-level, multimodal, or multi- and transdisciplinary approaches. And I think that we should claim that as a success, just having that point of view and having it be so mainstreamed at this point and accepted pretty much by all, is an accomplishment of the social science community that has hammered for 30 years this notion that, yes, it's a virus, but it's a virus, a pathogen that's always transmitted in human relationships. It's dyadic by nature as a transmissive agent. Those relationships are dynamic themselves, and they all take place in social and political contexts. And you have to look at all of this at the same time. We've been saying that for 30 years. But to re-show Carlos's schema, I think it's fair to say that even though that's now understood and to some degree accepted, we've done much better historically in the scientific arena, particularly in developing the biomedical and the behavioral strategies, and much less so in the social. So that's what we're going to focus on for the rest of our time. There have been a number of publications recently that have called very forcefully for more attention to social and structural approaches, from the basic social determinants kind of literature to the actual interventions, as you can see from just these few articles. And the one that Liviana mentioned that I was involved in from the AIDS 2031 project, we really did try to start to unpack what's involved in thinking about a social and a structural approach from a very pragmatic point of view. And our general starting point was to say that, at least in the States, and I think this may be generally true, there had been just this chorus of structural interventions. We have to develop structural interventions because we understand we need to address something at the social level. But there was a kind of forcing of the structural interventions conversation. First of all, the use of the word interventions right from the start, rather than approaches or programs or strategies, was forcing the whole discourse into the randomized controlled trial frame, which is very monolithic in the States for sure. And our feeling, and my feeling, continues to be that we haven't sufficiently mined the basic social science that underlies the development of social level approaches. We kind of jumped over a lot of the basic understanding of the social mechanisms that underlie vulnerability or conversely resilience at the individual and the group and population level. So that led us to try to then start unpacking the chain, the logical chain for approaching social level approaches, beginning with the conceptualization. So as probably is not news to any of you, HIV is transmitted by certain practices, and we prefer the word practices to behaviors for a number of reasons we can talk about later if you want, that occur in social contexts. And these practices and desires, another word we don't use enough, are influenced, if not shaped, by really core elements of social organization, familiar to sociologists and others, norms, values, networks, and institutions. And that these are constructs that underlie human interaction in social groups and underlie the notion of social drivers or social factors. There are some definitions that have been given, and I have to say we used the word social drivers in the paper because that was the word we were given. The group was called the Social Drivers Working Group of AIDS 2031. They said, we want you to write a paper on the social drivers of HIV. So we did it knowing that we mean drivers, factors, forces, and so on. But UNAIDS, because everybody kind of gloms onto the term du jour, took the drivers word and came up with their definition of social drivers. The social and structural factors such as poverty, gender inequality, and human rights violations. It's a somewhat arbitrary list, if you ask me, that are not easily measured, which is an important part of their definition, and then increase vulnerability. And then we have our version, which is more sociological, I guess I would say, these core social processes and arrangements, as I've mentioned, that operate around and in concert with individual behaviors and practices to influence epidemics. And it's really important, I think, for all of us to keep remembering when we talk about the social that we're not excluding the individual. These are obviously very interactive levels. Now, the other term that's very popular right now, and I think drives a lot of the work of the center here, is social determinants of health. And this is an old construct, and there's been social determinants literature in the social sciences for decades. But it's become a little bit more official now, or officially used as a frame by WHO, as you can see here, and by the U.S. Centers for Disease Control and Prevention. One of the articles that I had on the list earlier was written by Kevin Fenton, who's the head of the overall infectious diseases group there. So they're saying we have to take a social determinants approach now, but it's a similar construct of social drivers, these underlying fundamental processes that influence people's options and choices, behaviors, and practices. So once we sort of get an idea of what we're talking about at the conceptual level, these social forces, then we have to ask, how do they actually operate? And this is where things start to get tricky as we move towards designing approaches and strategies to address them. And the points that I think are, again, not news to you all is that social factors, social drivers, are not unilateral variables that you can say A causes B, and A works in and by and of itself, and you can isolate it and then connect it very directly to B. These drivers and process and factors are themselves interactive. We're all very complicated people, and we all have a whole lot going on as individuals as well as part of social groups and in social context. So they're complex, they're fluid, social drivers, they're nonlinear, and they're, of course, contextual. And, of course, they interact dynamically with the biological and the psychological and the behavioral and with other social factors. So we do have to characterize social drivers and factors contextually and situationally. And here I'm introducing what is always our dilemma about how much we do that without resulting in great reductionism, so that I can only talk about some individual who's some composite of gender, race, class, ethnicity, sex, history, birth order, language. I mean, you can go on down your list in their particular context and setting. And we don't want to go there because then we don't have a whole lot to say that's useful in the world. So that's part of our dilemma, and we'll probably say more about that. And we provide two examples in the social drivers paper that I'll just mention briefly here because they're a little counterintuitive, I think, to many people. You often hear folks try to talk in very unilateral causal terms and say things like gender inequality causes HIV vulnerability or contributes to HIV risk. Poverty causes HIV. That was a little bit of what Thabo Mbeki was saying when he refuted that HIV is a causative agent of AIDS. He was only half wrong. But to make just a very specific causal link like that is not correct because we have data in both cases. In the first case for gender inequality, specifically inequalities accruing to women relative to men in society, there are a number of places in which one can suggest that that's what's going on, like as I mentioned, the very disparate rates in infection rates between young women and young men in sub-Saharan Africa. A lot of folks have said that has something to do with the gendered arrangements that confer greater vulnerability to girls and women, make them more dependent on older men and things like that. But if you look at the Middle East and North Africa, where you have institutionalized, legalized gender discrimination, lack of property rights, the inability to go outside, having to wear veils, things like that, there are very low rates of HIV infection among women. Very low rates generally, but there is no disparate rate between women and men that is worse for women. So how do you explain that? Similarly, with poverty, there are lots of places and communities and settings in which poorer people do seem to have higher HIV rates. But if you look in the world, and particularly in Africa, where HIV is endemic in many countries, it's actually the wealthier countries, and in many cases the wealthier people in those countries, who have higher HIV infection rates. And it may have something to do with the ability to have broader social and sexual networks to procure sex through commercial sex transactions. Who knows? Or those are worth exploring. But the point is, you can't simply decide that poverty or gender inequality contributes to HIV in one linear sort of way. So charting these causal pathways can get somewhat complex, and some of the traditional methodologies that have been predominant in HIV from epidemiology tend to want to reduce things to the statistical association between two variables. Social epidemiology, which is a somewhat developed and emergent field, I think, has helped develop some more complex multi-level models that try to not resort to a single cause frame, but rather look at contributing causal factors, relative contributions, and also sees pathways that are often not linear, go one way and then the other way. And a lot of social scientists, particularly at the more theoretical end, will say, well, even those methods are much too mechanistic or too mechanical, because they still can't account for the things we know really matter in everyday life that have to do with meaning and the way people take up knowledge, they take up technologies, they take up and react to their interactions with researchers in a clinical trial setting, for example, or prevention providers, interviewers. They're not just passive people absorbing something. So how do we account for those meanings and reflections and the way those alter whatever it is that is being introduced? And so we talk a lot, we sort of introduce this notion of sociological plausibility and say we don't want to get trapped into saying you can't explain anything and there's pathways that just, are too complicated. But there's a possibility of saying, if based on current extant knowledge about how people are in their environments, if there's some sociological plausibility to a theory about how gender influences vulnerability or how poverty influences vulnerability, that's a reasonable place to start. You can use your sociological, your social science knowledge to build some plausibility, much like we do with biological plausibility in making arguments for drug approval and other things. So moving from the conceptual and starting to chart the causal pathways about how social factors influence epidemics or can be intervened upon, the next issue that I think we struggle a lot with in our field is the operationalization of these social factors and drivers. What are they exactly? How do we know them? How do we see them? How can we measure them and touch them in our worlds? And so we suggest a framework in which it's really important to do two things. One is to be really specific about the group of individuals the level that you're targeting, whether it's a group or an individual, whether it's broad social processes or factors around legal, environmental, or economic arrangements. And one that we don't talk about very much that we think is real important when you're thinking about operationalizing a social structural approach, and that is, are you really, if you're in an intervention frame or programmatic frame, are you really trying to change fundamental behaviors that people engage in, or are you just trying to make those behaviors more possible and safer, kind of like harm reduction does? And that's an important thing to keep in mind. People talk a lot about multiple concurrent sex partners as a driver of HIV epidemics in a number of places around the world. And when you start to think about interventions for that, it's a fair question to say, are you trying to reduce, is it necessary, whoever you are, is it necessary to reduce the number of partners, or is it sufficient to reduce the risk attendant with having multiple partners? What is it we're exactly trying to change, and why, and who's we anyway?